Howdy everyone, welcome to today's PhD showcase. One second while I share my slide. We'll get right into it because we've got a lot of really good content to get through. I'm the Director of Graduate Research Studies at NDRI, and I'm really honoured to be able to show the really broad range of research that our PhD students have been undertaking. Before we get into it though, I would like to acknowledge the traditional custodians on the land on which we're all meeting today and pay my respects to their elders past, present and emerging, and further acknowledge that sovereignty has never been ceded. So I've put up a very quick, blink if you miss it, list of all our presenters and presentations today. But rather than wasting time, I think I'll just hand it straight over to Amanti.
Thanks, Nick, for the introduction, and hello, everyone. I am Amanti. I will talk about the impact of pharmaceutical benefit scheme or PBS affordability reforms on opioid dependence treatment outcomes. I have shared my slides, and I hope you are seeing that. And this slide shows the burden of opioid dependence in Australia. In 2022, opioids were involved in 62% of drug overdose deaths. And the plot here shows overdose mortality rising over time, with opioids accounting for a large share. And in terms of prevalence, close to 84,000 people were dependent on opioids in Australia in 2023. And opioid agonist treatment, or OAT in short, is the frontline treatment for opioid dependence. Opioid medications reduce withdrawal symptoms and cravings related to opioid dependence. OAT is commonly delivered through supervised dosing at pharmacies or clinics, either daily as oral doses or weekly or monthly as injections. We have a strong body of evidence that OAT reduces illicit opioid use and improves health and social outcomes. And looking at the OAT system in Australia, on a snapshot day in 2024, around 56,000 people nationwide were receiving OAT at about 3,500 dosing locations. The OAT medicines funded through the PBS include oral liquid methadone, sublingual buprenorphine, and long-acting injectable buprenorphine, or LAB. And it is worth noting that around 80% of OAT clients receive their medicines through community pharmacies rather than public clinics in Australia. Around 90% of people with opioid dependence could benefit from treatment, but in 2023, only about 40 to 46% actually received treatment in Australia. While this is higher than the global average, it still reflects substantial unmet need. We are not suggesting that everyone with opioid dependence should be on OAT, but one factor that clearly limited access to OAT in Australia was the cost of treatment. And turning to out-of-pocket costs, the federal government supplies OAT medicines to pharmacies for free, but before July 2023, there was no funding to cover costs related to dispensing, and these costs were passed directly on to clients as dosing fees. And the people are receiving OAT through community pharmacies were charged around $2,900 per year before July 2023. And to put that in context, this was substantially higher than out-of-pocket costs for other chronic conditions, which were $326 per year in 2022. And this slide shows that the PBS reform is introduced on 1 July 2023. Under the new PBS system, general clients pay up to $31.6 per month out of pocket, and the concession card holders pay $7.7 per month. But there has been no published research examining how these PBS reforms have affected OAT prescribing patterns and treatment outcomes, and it is this gap that motivated my PhD study. Overall, my PhD uses a mixed methods approach to address 5 objectives. First, I review payment-related interventions in OAT. Second, I examine patterns of OAT prescribing following the PBS affordability reforms. Third, I explore the lived experience of OAT dispensing phase and the PBS reforms among people injecting drugs. And finally, I conduct quantitative studies to assess the impacts of the affordability reforms, one on injection opioid use frequency and another on the incidence of non-fatal opioid overdose. And I am showing here preliminary trends in OAT prescribing using national PBS date of supply data from July 2023 to November 2025. And overall, the total number of OAT scripts declined slightly from around 62,000 to just under 60,000. And what really stands out is the rapid expansion of LAB, which more than tripled over this period, alongside declines in both sublingual buprenorphine and methadone. And these are my references, and thank you so much for your attention.
Excellent. Thank you, Amanti. Just checking if we have any questions. There is a Q&A tab at the top that you can leave questions. Sorry, I should have mentioned that to begin with. I'm not seeing any for the current presentation, so we might move on to Emma's presentation, but there will be time for questions between each presentation. Emma.
Thank you, Nick. So I'm assuming all my slides are presenting okay. So yeah, thanks for the introduction. My name is Emma, and today I'll be talking a bit about my PhD, looking at the role of gender in young adults drinking. So to give some brief background, alcohol consumption is one of the leading risk factors contributing to the burden of disease in Australia, and it's particularly risky for some demographic subgroups. So young adults aged 18 to 29 are most commonly drinking at risky levels and have the highest proportion of acute alcohol-related harms. So for example, hospital admissions due to an intoxication-related injury. It's important to note that despite some population-level declines in alcohol consumption for younger generations, drinking, and particularly risky drinking, still peaks in this young adult age group. And there's also some important gender differences to be aware of in this space. So historically and today, men are known to drink more than women, and men are also more likely to engage in risky drinking and more likely to experience specific harms, such as alcohol-related transport or assault harms. But there are some distinct health risks related to women's drinking, such as an increased risk of breast cancer. However, there is a wider societal context to gendered perspectives on drinking that should also be addressed. So women's drinking only began to be normalized around the 90s onwards, with a new broader focus on women's freedom and empowerment. But recent evidence suggests that within alcohol research, women are now over-researched and over-problematized. And this notion is also reflected in the media, which tends to stigmatize and generate panic regarding women's, and specifically young women's, drinking as having dramatically increased over time. And so this has led to calls for gender-responsive research, where researchers explicitly acknowledge gendered perspectives and identify how gender is implicated in alcohol consumption and related harms. All of this leads me to my current research, where I want to understand how gender impacts young adults drinking in Australia. And specifically, I wanted to know if gendered drinking trends have changed over time, and I wanted to explore the attitudes and beliefs of young adult women and men regarding their drinking, to understand how young people conceptualize their own drinking and how young women and men might think about and use alcohol differently. So a snapshot of the results from my first study could be seen on the screen now, and where we looked at gendered trends in a number of drinking measures across multiple survey sources. These results indicated that alcohol consumption continues to decline for all young adult Australians, both women and men, across multiple measures, including annual volume, past year drinking, and risky drinking. As well, men continue to drink more than women across all measures and are more likely to be risky drinkers even today. When looking at the shapes of the trends, we can see some evidence for convergence, where drinking is becoming more similar over time, but this is actually driven by changes in men's drinking, where men's drinking has declined more steeply in recent years to closer match women's historically lower rates. The key takeaway from the study is that we're seeing young adult men's drinking declining at a faster rate than women's, but what we don't yet understand is why this is the case. there's very limited research exploring possible reasons for the decline in young men's drinking, and most qualitative research in this space focuses on adolescents rather than young adults, or on abstainers and light drinkers rather than heavier drinkers. And that brings me to my next set of results, where I'm currently in the process of analysing data from 29 interviews that I conducted with young adults across Australia. Participants were eligible for an interview if they regularly engage in risky drinking, which we defined according to the national guidelines as consuming 5 or more drinks in one occasion, at least monthly or more often. And I just wanted to outline some of the key themes that I'm already seeing across participants. So firstly, there seemed to be a bit of a disconnect between how participants think about alcohol in relation to health compared to their own personal drinking patterns. So many participants believed that their risky drinking was manageable with personal responsibility and had specific rules in place to help maintain this perceived balance between moderation and risk. So for example, one participant who said, I've learned just various things to make sure I'm a bit better myself. Like, for example, I actually don't drink beer. I find I get really stupid when I drink beer. Or this other participant who said, I've tested this out because we did a test because I hate being too drunk. And so 5.5 is my limit. The biggest gender difference that stood out to me so far is the different role that alcohol has in young adult women and men's lives. It should be noted that across all participants, alcohol had a pretty big role regardless. It's a way to socialize, spend time with friends, make new friends, engage with their community, and just build bonds with others. But the biggest difference, however, was that women tended to use alcohol as a facilitator, while men used alcohol as a requirement for socializing. So women use alcohol as a tool mainly to strengthen existing friendships. So for lack of better explanation, alcohol was secondary to the friendship. So for example, this participant who said, it's about coming together and doing girly things, like we drink while we're getting ready, like it's associated with the fun of getting ready and we have music blasting and it's like a positive friendship experience. Men, on the other hand, use alcohol as an essential item for socializing. So for a lot of men, alcohol came first and the socializing just couldn't really happen without it. For example, this participant who said, we kind of call ourselves a drinking team that plays rugby more than anything else. I guess that's kind of almost the culture. So putting all these results together, I hope to build a body of work that adds to our knowledge and understanding regarding young adults drinking with a gender-responsive lens. My work will allow for a nuanced understanding of gendered drinking trends, which is essential to avoid gaps in knowledge and inaccurate conclusions regarding young people's drinking. It's important that we know that young adults drinking is declining, but conclusions regarding gender differences in this space should be evidence-based to reduce the stigmatization of specific groups. As well, understanding how young adults use and perceive alcohol is the first step to understanding how best to reduce harms for this group. Given the changing landscape of alcohol consumption for younger generations, and especially the more dramatic decline in young adult men's drinking, it's important that we hear from young people themselves to understand how and why those who continue to drink heavily do so. Overall, combining both quantitative and qualitative approaches will aid in our ability to identify those most at risk from alcohol-related harms, informing future policies and co-designed interventions aimed at reducing harms in this population. And thank you very much.
Thank you, Emma. Fascinating research topic. We do have a question. Monica's asked, what was happening with the wider confidence intervals in your study from 22/23 in the NDHS male drinkers?
Yes, thanks, Monica. We did have some issues with the confidence intervals in those later waves. We were finding that I think it was the response rates were getting a little bit tricky in those later waves, and especially after COVID. So yes, from the top of my head, that was what was happening.
Thanks, Emma. I've not seen any further questions come in, so we may pass to Emmanuel, who will introduce himself and his PhD topic.
Thank you very much, Nick. So hi, everyone, and thanks for tuning in. For those who don't know me, my name is Emmanuel, and I'm happy to present some of my work today. This work is part of a planned thesis on the effect of law enforcement involvement on housing and employment among people who use drugs. So I'd also like to thank my supervisors for all their help and guidance thus far. So just quickly to give you an idea of the state of methamphetamine use in Australia, for those not too familiar with the statistics. Based on surveys, we know that Australia's prevalence of meth use is relatively high. Across 2022 and 2023, there was an estimated 200,000 Australians, or about 1% of the adult population, with past year methamphetamine use. There was also a long-term uptrend found in methamphetamine-related mortality between 2001 and 2020. Recent research suggests that this is underpinned by a decline in the purity-adjusted price of methamphetamine and an uptick in consumption frequency among regular users. We know that people who use methamphetamine are exposed to an elevated risk of physical and mental conditions, as well as a number of social disadvantages. So today I'll be focusing on unemployment with regard to this social disadvantage. So we know that labour market participation is a core social determinant of health and assistance, with justice-involved meth users sitting at the intersection of drug, housing and labour market systems. Law enforcement involvement, especially repeated arrest, is not just a consequence but a driver of worsening employment. So we wanted to explore the effect of arrest as it represents the most immediate point of formal law enforcement involvement. We used data from VMAX, which is a large prospective cohort of people with a history of regular methamphetamine use in Victoria, Australia. And on average, interviews occurred every 6 to 12 months, depending on whether they occurred pre or post-COVID. We analysed participants' self-reported employment status and arrest frequency from each interview, while also adjusting for demographics and related factors. So with this data set, it allowed us to examine longitudinal associations between frequency of arrest and changes in employment over distinct points in time. So let's get to some preliminary results. So from a final sample of 646 participants, a total of 301 participants were employed at any stage in the study, with 369 participants reporting at least one arrest in the same period. We found that multiple arrests was associated with a reduced likelihood of transitioning from unemployed to employed between interviews compared to having no arrests. For this transition, so going from unemployed to employed, there was no significant association for having a single arrest. However, with the second transition type, so analysing transitions from employed to unemployed, we found that participants with a single arrest and also those with multiple arrests had an increased risk of becoming unemployed between interviews. And the risk was more severe for those with multiple arrests. So here you can see the significant adjusted relative risk ratios, and on the right yellow bar of the graph, that a single arrest was associated with an increase in the risk of becoming unemployed, whereas multiple arrests were associated with a significantly higher risk of becoming unemployed compared to having no arrests. And then the red bar on the left shows a reduced likelihood of becoming employed following multiple arrests compared to having no arrests. So there's a few possible mechanisms by which arrests may have a detrimental effect to employment outcomes, including the fact that employers are less willing to hire individuals with a criminal record following arrest, or that arrests could cause mischiefs and loss of employment. What we do know is that the results highlight the need for a combination of diversion programs, reform policies around criminal records, and the further development of employment support programs for individuals that fall into this population to improve their employment outcomes. So as I mentioned earlier, the preliminary results I've just presented are part of a broader body of work that will make up my thesis. Currently, we have a paper under review on associations between arrests and housing transitions. There's also a scoping review well underway, which looks at how employment outcomes are measured among populations of people who use drugs. And up until now, my work has been based on self-report data in VMAX. So we also plan to publish work which utilizes official linked administrative data that has been recently acquired. So thank you very much for listening.
Thanks, Emmanuel. Might just give people a moment if they have any questions to leave them in the Q&A tab. Okay, not seeing much movement, so we can also take more questions at the end if one does occur to you while you're watching. But in that case, we may hand over to Shady for his presentation on his thesis topic. Shady, you're on mute.
Hello, everyone. Sorry about that. Let's take this again from the top. Can everyone see my presentation now? Yeah?
Sure can.
Beautiful. All right. So my name's Shady, and I'll be talking about the medically supervised injecting room and health outcomes in people who inject drugs. Start off by acknowledging the traditional custodians of the land, the Wurundjeri and Bunurong peoples, and pay respect to their elders, past, present, and emerging. I want to thank my supervisory panel as well. Today I'll be talking a little bit about my thesis titled The Impact of Medically Supervised Injecting Room Utilization on Health Outcomes in People Who Inject Drugs. Essentially, we're looking at a few different impacts that MSIR has had on the supermix, on participants in the supermix cohort. In terms of the outcomes we're looking at in my work, so we're looking at the first outcome we looked at was a methodological aim, which has been published, which was essentially developing a cohort attrition profile for supermix. Today we'll be talking a bit about oral health. Other outcomes we're looking at with my thesis include ambulance attendance for non-fatal opioid overdose and hospital admission for SSDIs. Starting off with oral health, so we're aiming to essentially assess the effect of MSIR use on oral health levels within supermix. And a little bit of background, so people who use drugs generally have worse levels of oral health compared to the general population. There's a few different reasons behind that, both structural and on an individual level. And oral healthcare in general has been shown to improve ARD treatment outcomes and subsequent integration into society. And while there aren't that many studies looking at all of this, the studies that are there are mainly cross-sectional in nature. MSIR, when that was established in 2018, ran an oral health program. So essentially it was oral health screening, looking for decay, looking potentially providing referrals as well, in addition to topical treatment to kind of stop any dental decay. And with that in mind, what we aim to do was to essentially assess the impact MSIR might have had on levels of self-reported oral health within the supermix cohort. So we used self-report data from July 2018 up until November 2024. And what we did essentially was use an oral health outcome. So the supermix, using the self-report data from the supermix questionnaire, which essentially had a 5-point oral health question, so essentially a 5-point Likert scale, asking participants or individuals to rate their oral health. And it started from very poor and went all the way up to excellent. To simplify this, we kind of recoded it into a binary category. So we just grouped together very poor and average and excellent, average, good, and excellent into another category. Now, the exposure we looked at was essentially MSIR use within the past 12 months. And then when it came to developing our statistical framework, we used DAG to describe the data generating process. And what DAGs allow us to do is essentially identify time dependent, which are these pink nodes here, confounders, and time invariant, fixed confounders like age, sex, birthplace, etc. So those are grouped here in the vector confounders, and then we have at different time points, so different point 1, 2, and 3. We've got our time varying or the time dependent confounders. We have our exposure here and our outcome here, so MSIRs and oral health at the different time points. And this allowed us to put together our statistical model. So we used GEEs to estimate the effect of MSIRs. Now, apologies, I was just advised before we started now that I'm not going to be able to share these results. First of all, are preliminary, so I would ask you to please not share or disseminate them anywhere. But in addition to that, I've just been advised I'm not, technically speaking, I can't share the provisional results we had from the models. So I can share these baseline summary statistics, so just associated with graphic details. The table 1 basically I can share, but at this stage, at this point in time, until we get permission from the Department of Health, I can't share the provisional results we had from our statistical models. I'll discuss very briefly. I can very briefly discuss what we found, but I can't share the actual kind of tables. So I just had to remove those now. Essentially, we had 934 participants. And the majority of participants within our sample had not seen a dentist in the past year, and just under half of them had reported poor or very poor levels of oral health. Now, what I can share with our statistical model is that with essentially long-term MSIRs, we saw a protective contemporaneous effect on oral health. So meaning that when we modeled essentially for adjusting for prior MSIRs, 1 year, 2 years, 3 years, and 4 years prior, we saw consistently protective effect. So what that translates to is improved oral health. So we saw participants' oral health scores, self-reported oral health scores, improve as time went by. So very briefly, with regards to the discussion, there is a potential benefit to ancillary services like oral health screening. This needs to be researched further, of course, just to understand the underlying mechanisms, what's direct, what effect is direct, and what's indirect here. There are limitations, of course. First one being that we're using self-report data in addition to the outcome itself. So we use the self-reported oral health question as opposed to oral health-related quality of life, which is an outcome, which is a measure that's been used in quite a few studies looking at oral health in people who inject drugs. So this may impact the generalizability of our findings. With regards to the other 2 outcomes we're looking at for my thesis, so we're looking at ambulance attendance for non-fatal opioid overdose. Currently in the process of working with the linked dataset, we'll be adopting a very similar kind of statistical framework. So we've already developed the DAG for that, and we've worked with some self-reported data, but we're currently running the models with the linked datasets. And last but not least, looking at hospital admission for SSTIs, it's a similar story, albeit with a much busier DAG. So very similar kind of statistical framework that will be applied there. These are the references I used. Thank you very much.
Thank you very much, Shady. And I'm sure we're all looking forward to when you can share those provisional models. Sorry to jump around a bit, but we have had a flood of questions for Emmanuel as during your presentation. So I might just jump to those. Emmanuel, Simon asks, could arrests be a marker for increasing methamphetamine use and related chaos and other harms which could independently predict loss of job, or is that controlled for in your analyses?
Yeah, that's actually controlled. One of the control variables was meth use frequency. So we did actually find that going from employed to unemployed, 1 to 3 days per week, meth use was actually associated with becoming unemployed. But once this was adjusted for all the other covariates, this was no longer significant. But yeah, to the short answer to your question, yes, it was adjusted for.
Okay, just to share it around a bit, I'll give one to Shady as well. So again, Simon asks, I may have misunderstood. Did you say that the oral health was a 5-point scale that you had? Sorry, the oral health was a 5-point scale, and you collapsed the top 2 and bottom 2 levels. Does that mean you dropped out 5th, the neither category or the middle category scale response, or are they incorporated in the model?
Sorry, I probably didn't explain that well. So no, we didn't drop anything out. So we essentially we recoded the 5 points. So we had poor, very poor, and then it was average, good, and excellent. So we grouped. No, we didn't drop anything. So we included all 5. It was one category, one variable had 2, which was poor and very poor, and the other one had essentially 3, which was good, very. I mean, average, excellent, and good. So no, we didn't drop anything.
Excellent. Another one for Emmanuel from Peter Higgs. Just a clarification, were you looking at any kind of employment, for example, casual or part-time? Is there a threshold for the level of employment you're looking at, or was it just full-time employment?
Yeah, because the data is limited in terms of hours worked, we've just gone with any employment for the employment variable.
Excellent. Okay, just being mindful of time now, we'll pass to our final speaker, Julia. Please go ahead and introduce yourself and your thesis topic as well.
Thanks so much, Nick, and thanks for the opportunity to present today. My topic is around the commercial interests in alcohol policy processes in Australia. And I'd like to acknowledge my supervisors who've supported me to recently submit my thesis for examination, including my principal supervisor, Professor Tanya Sikritzis. So my thesis recognises that the health and social impacts of alcohol on Australian communities have continued in an environment where alcohol policy is not closely aligned with the research evidence. Industry influence on alcohol policy agendas is recognised as an impediment to the effective regulation of alcohol. So my thesis aims to investigate the strategies used by actors with commercial interests in alcohol to influence alcohol policy processes, and investigate considerations for protecting alcohol policy processes from the influence of commercial interests. My thesis includes 3 published papers of studies that examined what evidence was used and how evidence was used by industry actors in submissions to alcohol policy consultations. We found that 9 in 10 industry submissions denied the effectiveness of strategies that were supported by evidence, and 6 in 10 submissions misused evidence in some way. And these practices were consistently high in submissions by alcohol trade associations and major alcohol producers and retailers. In a qualitative study that's not yet published, I explored the perspectives of government stakeholders regarding conflicts of interests within alcohol policy development processes. So I interviewed 15 people with current or former roles in government or parliament with experience in alcohol policy consultation processes. I constructed 7 themes from the data. In the interest of time, I'll touch on 4 of those themes now. And for each theme, you can just read one example quote on the slide. So the first theme I'll share is that alcohol industry representatives were viewed as legitimate and active stakeholders and were largely treated as any other stakeholder. So based on the interviews with these government and parliament stakeholders, they saw that industry representatives were perceived to have substantial access to policymakers outside of structured policy consultations, facilitated by political donations, by lobbying and attendance at events. The industry's access was perceived to be unmatched by other stakeholders and enabled the building of relationships, which could have a material impact on how industry arguments were received in the future. The second theme I'll share is that alcohol industry influence is believed to have delayed and deterred government health policy. So participants pointed to specific instances where they believed the alcohol industry had exerted a direct influence on alcohol policy in line with their commercial interests. For example, watering down and significantly delaying the national alcohol strategy and delaying mandated pregnancy warning labels on alcohol packaging. Participants also noted the industry's indirect influence, which made it difficult to be certain of what roles, if any, industry influence had on policy outcomes. A broad outcome of industry influence was seen as government being dissuaded from progressing alcohol policy reforms. The third theme I'll share is around the absence of existing commercial conflict of interest protections for alcohol policy. So most participants perceived an absence of formal protections from conflicts of interest that apply in alcohol policy development. Participants recognised the chasm between how commercial conflicts of interest are managed for the alcohol industry compared to the tobacco industry. And this included in terms of the appetite to address conflicts of interest, to which clear guidance, and also the extent to which clear guidance sets boundaries on acceptable engagement with industry. And the fourth theme I'll share is around support for additional alcohol policy protections. Almost all participants expressed a degree of support for additional protections for alcohol policy from commercial conflicts of interest. However, there was variation in the protections suggested by participants. There was support for a more nuanced approach to setting boundaries on the alcohol industry's role than outright excluding them. Several participants were supportive of applying the principles of the Framework Convention on Tobacco Control, Article 5.3, to the alcohol industry, and that would require protecting the setting and implementation of alcohol control policies from commercial interests, and would require government officials to interact with the industry to the extent strictly necessary to effectively regulate alcohol products and the alcohol industry. So my thesis brings together insights from public domain data about strategies employed by industry actors to influence Australian alcohol policy processes, and complements that with valuable insights from a key informant group into forms of industry influence on government policy that are largely designed to be invisible. So this research provides evidence in an Australian context of strategies used by industry actors to distort, deny and ignore evidence in line with their commercial interests, and it provides evidence of the need to treat industry actor representations of evidence with extreme caution. The research adds to the rationale for developing clear boundaries on industry participation in alcohol policy development processes, and it also reflects support among government stakeholders for an alcohol equivalent to Article 5.3 of the Framework Convention on Tobacco Control, adding to the support already documented from researchers and alcohol harm prevention organisations. Thanks so much. That's all from me right now. Thank you.
Fantastic. Thank you, Julia. And congratulations as well on submitting your thesis. A huge milestone, huge achievement. Do we have any questions for Julia in the chat? I'm not seeing any. I might ask one. So just curious, obviously the alcohol industry is sort of multifaceted in a way. Often we refer to it as just the alcohol industry, but there are, several different competing interests there. Did that ever matter in your work? Did that ever differentiate? Were producers advocating for different things to retailers, or?
Yeah, no, it's a good question, and we did explore that a bit in the research, and did seek to be mindful that while we often talk about the alcohol industry as one, there are quite diverse groups within that. We also were mindful of other industries, allied industries that that have an indirect interest in alcohol, so advertising, music industries, and some others. So we considered their submissions in these analyses as well. There were distinctions between different segments of the alcohol industry. As I mentioned, that we saw those concerning tactics of industry around denying the evidence and misusing evidence, particularly in trade association and major retailers, major producers submissions, particularly. There was a distinction between licensed premises, so submissions from licensees use some of those techniques a bit less than others. And also in the interviews, there did come up some distinctions. Some of the government stakeholders were quite positive about some of their participation and the information that they get from licensees, given that they're more closely connected to their communities compared to some of those concerning tactics that are often seen by the peak bodies, trade associations and major companies. The government stakeholders were a little less flattering of the kinds of information that they receive from those big end of industry.
Excellent. Thank you for that answer. I can see we probably have time for one more, our last question again from Emmanuel. Emmanuel, are there any data regarding the % of people getting re-employed after loss of employment, or how long it took for them to find employment compared to other populations?
Yeah, thanks for all the questions. So there's no specific data on that, but it's a great consideration. So I plan to look into that. But we've found that some participants are flipping between the two quite a lot, between employed and unemployed, up to 4 times is the range, 1 to 4 times. But yeah, specific data we don't have yet. Thank you.
Okay, excellent. That is all of the time we're going to have today. Thank you everybody for coming, and especially thank you very much to our PhD students for their excellent presentations and even more wonderful research. The NDRI webinar series is back. We'll be back every month. As you can see, in April, we have a webinar planned, the perspectives from Aboriginal researchers. So hopefully we can see you all there. Thanks, everybody.